Welcome to session 3 and thank you for sticking with me. And as promised, I'm going to talk you through a series of 12-lead ECGs or EKGs utilising the systematic approach. And then afterwards I've left a series of examples for you online that you can practice independently utilising the systematic approach, and you can have a look at my answers and information there as well. But let's stick together for the moment. And here's the first example, and imagine that this has been handed to you by a colleague in clinical practice who says, what's on this recording? Which is a fair question. Well, to answer that, work systematically. First of all, ascertain that it has been recorded accurately, and as you know, if you're in any doubt and you're able to, re-record it. Is it a clean trace? Certainly is. The lines are nice and sharp and clear, and they progress horizontally across the paper. Check your calibration, and although absent here because it's a textbook example, you must see 25 mm per second printed on the recording, normally on the bottom left. You must also see the box calibration, and it must equate to 2 large squares high, and it certainly does here. The next important question is the patient in sinus rhythm. And remember, if they're in sinus rhythm in one lead, they'll be in sinus rhythm across the rest of the recording. Well, to answer that, we have a look at the rhythm strip printed along the bottom of the ECG or EKG, and that's because it will give you the maximum number of complexes and therefore a great deal of data to work with. But you'll notice here that the rhythm strip is V1, and that's quite unusual. It's normally lead 2. That's because lead 2 is a very positive or upright lead, and therefore arrhythmias appear more familiar. So I'm going to look at the rhythm strip, but also I'm going to look at lead 2. As you now know, what I'm looking for is one clear rounded P wave per QRS complex and T wave. I'm not getting that. This patient is not in sinus rhythm. If you look between the QRS complexes, what you see is this constant undulating, fibrillating, wobbling baseline. And when the heart rate is normal, you should see a flat line somewhere, the isoelectric line, certainly at the end of the T wave and before the next P wave. You certainly don't see that here. It's constant churning electrical activity within the atrial area. Therefore, it's impossible to say what the PR interval is, and as stated, impossible to say there is one P wave per QRS complex. But just hold that information. The patient is not in sinus rhythm because we'll start pulling the clues together. But let's have a look at the QRS complex. Well, it's fine. It's nice and narrow, and it's a lovely shape. It's nice and sharp, and it's no wider than 3 small squares at its widest point. It's much narrower, in fact. It's fine. It's normal. Therefore, we can apply the general rule. If the QRS complex is narrow, it's highly likely that this is an atrial arrhythmia, because the ventricles say, as long as you send depolarization down the normal ventricular pathway, that's the bundle branches, we will give you a normal QRS complex. What about the heart rate? Well, before you calculate the heart rate, you need to ascertain whether you've got a regular or irregular rhythm. To do that, you place a piece of paper, as you now know, over the 12-lead ECG, and you mark off 2 R waves next to each other. You move the piece of paper along, and subsequent R waves should align with those marks on the paper if it's regular. If it doesn't, it's irregular, and it doesn't here. It's an irregular rhythm. Therefore, alarm bells are ringing that this is highly likely to be atrial fibrillation. It may not be, but it's highly likely because the most common cause of an irregular heartbeat, and you could take the patient's pulse as well and feel that irregularity, is atrial fibrillation or AF. So how do we calculate the heart rate if it's irregular? Well, we've gone through that. There are various ways of doing it, but I recommend that you count out 30 large squares and count the number of R waves within that 30 large square period, because that equates to 6 seconds. There are 8 R waves, or 8 complexes, 8 QRS complexes, within the 30 large square period. You times that by 10 to give 60 seconds, and the heart rate is 80. Remembering, of course, that it will vary from minute to minute because it's irregular. So, heart rate on that calculation is 80. Next, we have a look at the leads. Well, if we look at AVR, it's very negative, as it should be. We look at lead 1, is very positive. Lead 2 should be very positive. It should be the most positive, but it's not. In fact, the R wave is as tall as the S wave is deep, and lead 3 is very negative. We're not going to look at left or right axis deviation here, but what I will say to you is the cardiac axis is heading towards the left. It's heading towards lead 1. You can look up left and right cardiac axis deviation, but all I'll say at this point is I'm just suggesting that that cardiac axis is heading more towards the left than it should be, but I'm not doing the extra calculations to ascertain exactly whether it's left or right axis deviation, but you can look that up. We look at the chest leads, V1 to V6, sometimes known, as you know, as C1 to C6, and it progresses from negative to positive. And it looks as though V4 is possibly the most positive, but that's fine. It's progressing from negative to positive. So we need to pull all of the clues together. You do not have sinus rhythm. Instead, you have this constant churning, electrical activity within the atria. The heart rate is irregular, but the QRS complex is normal, so it's highly likely to be an atrial arrhythmia. There are no other abnormalities, although I'm suggesting to you that the cardiac axis is heading more towards the left. Therefore, we have atrial fibrillation with a heart rate on this calculation at 80 beats per minute, being aware that the heart rate will vary from minute to minute, and in fact may alter on differing calculations. But you can give a fairly accurate heart rate, but as I've said, it is altering from minute to minute. There's atrial fibrillation on this calculation with a heartbeat of 80 per minute. Okay, here's the next example, and I'm sure you gave a little gasp when you saw this because it's quite busy, isn't it? But even before you start your systematic review, you'll be drawing some conclusions. For example, it's a very fast heart rate, isn't it? And also the QRS complex is narrow, which is suggestive of an atrial arrhythmia. But let's look at it systematically together. Is it a clean trace? It certainly is. Nice and sharp in terms of the lines, the complexes, and also it progresses horizontally across the page. You must see 25 millimeters per second printed on it as part of the calibration. You don't here because this is a textbook example. I still think that's a bit naughty. You need to see that. But the box calibration on the left equates to 2 large squares high. So remember, your speed calibration and your height calibration must be printed on the 12-lead ECG. The big question is this patient in sinus rhythm? So you need to look at the rhythm strip printed along the bottom. You don't have one, that's fine. Look at lead 2. Well, this is a very, very fast heart rate, and when rates are very high, it's almost impossible to see a P wave. You might see a bit of a P wave, or you might see no P wave at all, because even if it's there, it's blurred in or disappears into the QRS complex. What you're seeing between the R waves here could be a P wave, could be a T wave, impossible to say. So at the moment, we cannot say with certainty that this is sinus rhythm. Therefore, we can't answer the question, what is the PR interval, and is there one P wave per QRS complex? We simply can't. So let's move on to the QRS complex. Is it narrow? Is it broad? And what's the shape? Well, it's a nice shape, nice and sharp, and it's narrow. It's no wider than 3 small squares at its widest point. So we can start to ascertain that this is highly likely to be an atrial arrhythmia, as we said at the beginning. What's the heart rate? Well, before you do the heart rate, you need to make sure that this is a regular rhythm. But I would say when rates are very high, even an irregular rhythm can appear regular. But you still need to measure for that. So place a piece of paper over the 12 lead, mark off one R wave, mark off the R wave next to it, move the paper along, and subsequent R waves should fit over those marks. Remembering, again, it can appear regular even when it's irregular in very high heart rates. Okay, we're presuming this is regular. We count the number of large squares between the R waves, and I want you to do this accurately, but from what I'm seeing, it appears to be 1.2. Divide 300 by 1.2, you can do that, and you'll see that the heart rate is just under 300. It's incredibly fast. Look at the leads. I'm looking at the limb leads, and I'm noticing AVR, or VR as it's labelled there, is very negative, as it should be. Lead 1 is the tallest there, just about. Lead 2 is still very tall, so that's fine. And look at the chest leads. They progress from negative to positive. In fact, they change to positive quite early on, but they do progress from negative to positive. Okay, let's pull it all together. You've got a very high heart rate. You have a narrow, complex QRS. You can't tell whether they're in sinus rhythm. So what we call this is a narrow, complex tachycardia. It's so fast we can't see anything more about the atrial activity. And sometimes it's called a supra, meaning above, a supraventricular tachycardia, an SVT. I don't generally like that term because it's implying with certainty that the impulse is in the atria, and you can't be absolutely certain. This impulse could be driving the heart from high up in the ventricle and giving a very narrow QRS. It is possible. So we call it a narrow complex tachycardia, but it's highly likely that the impulse driving the heart is in the atria. It is unlikely to be sinus rhythm, even if we slowed it down, because if somebody is in front of you, in the bed, in the chair, on the couch and so forth, resting, and they have a heart rate this high, it's very unlikely it would be sinus rhythm, very unlikely indeed. What I would say is you need to assess the patient's hemodynamic status immediately by taking the blood pressure and other measurements, looking whether they're cold and clammy and so forth, because this needs to be treated promptly. This is an emergency. You can't have a patient with a heart rate this high and allow them not to be treated promptly. This will probably be by pharmacological method, could be by cardioversion, and then later on they'll need to be treated probably in a catheter lab. It is a narrow, complex tachycardia. We cannot be certain it is sinus rhythm. Here's the next example, and let's look at this systematically together. Is it a clean trace? Certainly is. Nice sharp lines. Do they progress horizontally across the page? Yes, they do. A little bit wavy in the lines, but generally they progress horizontally. You must see 25 millimeters per second printed on the 12 lead. You don't here, it's a textbook example, but you must in clinical practice. And the box calibration on the far left for the height of the complexes does equate to 2 large squares high. Is the patient in sinus rhythm? Well, I'm looking at lead 2 because I don't have a rhythm strip, so I look at lead 2, and certainly yes. I'm seeing a P wave which follows the T wave. There's a flat line after the T wave and then you have a P wave. And remember, if you're seeing sinus rhythm in one lead, it's sinus rhythm across the 12 lead ECG. So we can measure the PR interval, and that falls within the normal range of 3 to 5 small squares, or 3 small squares to 1 large square. And there is 1 P wave per QRS complex. So there is no sign on this 12 lead ECG of heart block. Look at the QRS complex. I'm particularly looking at V4 and V5 and the shape and the width. It's certainly a nice shape, nice and sharp, and it's no wider than 3 small squares at its widest point. It can be on 3 small squares but shouldn't be any wider, so that's normal. This is not indicating there is conduction problems in the ventricle. Measure the heart rate. Check it's regular, as we've described right the way along. So again, mark off 2 R waves next to each other on a piece of paper, move it along, and the subsequent R waves should fit. It is regular, and I'm counting there 4 large squares between 1 R wave and the next. So we have a heart rate of 75, nice steady heart rate, and they're in sinus rhythm. So it's not sinus tachycardia, it's not sinus bradycardia. Let's look at the limb leads. We'll look at those on the left of the ECG. We see AVR, or VR as it's labelled there, is negative as it should be, inverted P wave and T wave, that's fine. And I'm not certain whether lead 2 or lead 1 is the tallest, but that's fine. Lead 3 isn't quite so tall. And the chest leads progress from negative in V1, sometimes labelled C1, to positive in V6, sometimes labelled C6. And V5 there is the tallest, which you often see. So now you've been champing at the bit for me to look at the abnormality, and certainly if you look at leads 2, 3 and AVF, you're seeing a blurring of the QRS complex with the T wave. That's the ST segment, it's elevated. And many of you watching and listening will know, with a good clinical history and with biochemical markers such as troponins, that is indicative of a myocardial infarction. Remember your adapted form of the hexaxial reference system, and you'll remember that leads 2, AVF and 3 cluster together in the inferior part of the heart, the low down part of the heart. So it's not surprising to see the ST elevation in those leads because they're close together. Inferior, and so we call it an inferior myocardial infarction or an acute inferior myocardial infarction. Inferior meaning it's the low down part of the heart. A couple of other things to point out to you. Have a look at V1, particularly V2, V3, and you'll see that the ST segment does the opposite to the inferior leads. It drops. It's horizontal depression. And when we see ST depression horizontal, that is indicative of ischemia, and that's not uncommon to see as an ischemic zone around the infarcted area. And in fact, when you have an inferior myocardial infarction, very commonly you see those leads, the early V leads or C leads, demonstrating ST depression. Conversely, if you see ST elevation in the early V leads, you see ST depression in the inferior leads. That's not uncommon. And the other thing to point out is if you look at lead 3, you'll notice after the little P wave there, it drops down. You've got a Q wave before the tall R wave. This is not unusual in a myocardial infarction that has been allowed to progress for a number of hours. A Q wave is growing, and that will grow if untreated, and that will stay forever. So you can look at a 12-lead ECG sometime later, providing the patient has survived, of course, and say, well, you've got signs of an old myocardial infarction. I have to say there are other occasions other than myocardial infarction when a Q wave may be present, but again, with your history, talking to the patient, etc., you may come to the conclusion that they are showing signs of an old myocardial infarction. So what we're seeing here is a patient with a very steady heart rate, they're in sinus rhythm, and they are demonstrating signs of an acute inferior myocardial infarction. But again, you use the 12-lead ECG as part of a holistic assessment, and you need to see other signs, clinical history, and other measures such as biochemical markers to be absolutely certain that is what the patient is experiencing. When you get a 12-lead ECG or EKG like this, you just think, where do I start? Because there's such a lot going on. But just work systematically through. And a tip for you, sometimes you may not be able to name the arrhythmia, but you can certainly say a lot about what's going on. Is it fast? Is it slow? Is it atrial in origin, ventricular in origin? There's a lot you can say, even though you may not be able to name it. But let's look at this systematically together. You need to ascertain that it's been recorded correctly. You need to check that it's a nice clean trace, which it certainly is. The lines are nice and sharp and clear, and it progresses horizontally across the paper. You've got your 25mm per second calibration. No box calibration, and you must see that in clinical practice. We're looking for 2 large squares high on the box calibration, but we'll assume here that it is calibrated correctly. Is the patient in sinus rhythm? Well, have a look at the rhythm strip, and luckily it's lead 2, printed there along the bottom of the 12 lead. And certainly we have P waves, we have sinus activity. But your eye will already be saying there's a rather odd association between the P waves and what appears to be a rather bizarre QRS complex. Well, let's pick that apart. If you look at the P wave that follows the first QRS complex in the rhythm strip, you'll see that the PR interval is too long. Look at the P wave before the third QRS complex, and the PR interval is even longer. Look at the P wave before the fourth QRS complex, and the PR interval is even longer. And then following the fourth QRS complex, you have a P wave on its own. It doesn't conduct down into the ventricles. There's no QRS complex following it. In fact, you get another P wave with a normal PR interval. This cyclical pattern, where you're seeing a PR interval getting longer and longer and longer and then missing a beat, is known as the Wenckebach phenomenon, or Mobitz type 1 second-degree heart block. And this is a sign of atrioventricular node or AV node disease. It's quite serious. But a word of warning. This could be complete or third-degree heart block, where no P waves are getting through the AV node, but because you have a short rhythm strip of only, in fact, I think 6 complexes there, you're seeing a pattern that may be occurring by chance. So wherever you have questionable association between P wave and QRS complex, do print off a long rhythm strip, maybe 2 to 3 times the length of the 12 lead, so that you can really see whether there is or isn't an association between P waves and QRS complex. Now let's have a look at that QRS complex. Well, it's less than 3 small squares, but it is a bizarre shape, and that's what I want you to focus in on. The bizarre shape suggests that the QRS complex is emerging from within the ventricular wall, rather than coming down the fastest pathway, which, as you know, is the bundle branches. So this is adding to the suggestion that this could possibly be complete or third-degree heart block, and the ventricles are staying alive by generating their own slow impulse to keep themselves contracting. Let's look at the heart rate. Well, the QRS complex is occurring at about 65 beats per minute if you count the number of large squares between them, and I want you to do that accurately always. And you'll assume that there is 1 P wave per QRS complex regardless of the PR interval. But whenever you have questionable association between P waves and QRS complex, not only do you need to print off a long rhythm strip so you can see any patterns or not that are occurring, but you need to mark off your P waves. Let's do that. We're marking off 2 P waves that lie next to each other, and then moving the piece of paper to the beginning of the rhythm strip, we put a P wave against the first mark, and suddenly you see that P waves are occurring not just before QRS complexes and not just after, but in QRS complexes as well, because there's no association here between P waves and QRS complexes. Complete dissociation. The AV node at this moment in time is not conducting through, so the ventricles are keeping themselves alive by releasing their own slow impulse. Now, the only true golden rule of third-degree heart block is there will be dissociation between P waves and QRS complex. The QRS complexes do sometimes appear in a normal shape or narrow, particularly if the escape beat is high in the ventricles. Often you do get a slow escape beat. It looks abnormal, but you can't always guarantee it. But by its nature, complete or third-degree heart block will have dissociation between P waves and QRS complex, so always mark off those P waves and print off a long rhythm strip. Now, in looking at the leads, it's impossible really to look at them because the cardiac access is not following its normal pathway from 11 o'clock to 5 o'clock because the QRS complex is emerging from within the ventricular wall, so we really can't do that. What we can do is pull the clues together. You've got dissociation between the P waves and the QRS complexes, and you've got an abnormal shaped QRS. The ventricular rate is in fact quite normal at 65. In complete or third degree heart block, this is often slow, and you do often have a bizarre looking QRS. But the only golden rule is that you will get dissociation between P waves and QRS complexes. So remember again, do mark off your P waves, do print off a long rhythm strip. So we have complete or third degree heart block. This patient is highly likely to require pacing, perhaps temporary, then moving on to permanent. This is the final example I'm going to talk you through. Then we need to get you looking at some examples yourself, working through them systematically, and we'll give you some written answers to those. Okay, let's start by saying, is it a clean trace? Lovely, very nice and clear and sharp. You haven't got 25 millimeters per second printed on it, but in reality, in clinical practice, you must see that. Box calibration is there on the left and equates to 2 large squares high. Is the patient in sinus rhythm? I'm looking at lead 2 and remembering if they're in sinus rhythm in one lead, they will be in all leads across the 12 lead. Yeah, they're in sinus rhythm. Be confident there. Maybe that P wave's a little bifid, a little odd shape, but it's okay to me. It's rounded and it is just coming before the QRS complex. So we can measure the PR interval. We can see that it falls within 3 to 5 small squares, or 3 small squares, 1 large square. There is 1 P wave per QRS complex, so that's good. We can then look at the QRS complex, beautifully sharp and narrow, very, very nice indeed. Notice in V4, V5 and V6, and I think V3 as well, The T wave is inverted. I'll come back to that, but it is upside down, so do have a look at your T waves whenever you're looking at your 12 leads as well. Then we have to look at the heart rate, and I'm going to leave you to calculate that. It appears to be four large squares. You need to mark that off with a piece of paper and do it accurately, which would equate to 75 beats per minute. Next we go through the leads, and we notice in the limb leads AVR is negative, as it should be. We notice that lead 1 is actually the tallest. Lead 2 is still quite tall, so your axis is heading a little bit towards the left ventricle. Lead 1. You would need to measure more precisely to diagnose left axis deviation. I would suggest from my experienced eye that it isn't, but you would need to measure that. We don't cover that in this workshop, but that's something you may want to hopefully be motivated to go and have a look at. We then look at the chest leads, and we see they progress from negative to positive. Very positive in V4, V5, V6. You notice how those R waves blur with the complexes above them. Now this is significant. If your calibration is correct on the far left and your box calibration is 2 large squares high, then your R waves are a true reflection of the electrical activity within the patient. The R wave should not be as tall as that. And when it is taller than 5 large squares, which is 25 millimeters per second, it is highly suggestive of left ventricular hypertrophy, that is enlargement of the left ventricle, therefore generating more electrical activity. So one would want to know more about this patient. Is there truly, an echo would show that, left ventricular hypertrophy, which may be a sign of prolonged hypertension, heart failure, which has a variety of causes, etc. Why this is suggestive also of left ventricular hypertrophy is those tall R waves are accompanied by upside down or inverted T waves, which is not uncommon to be associated with the tall R waves in left ventricular hypertrophy. Conversely, look how deep the S waves are in V1, little R wave to start with, then a deep S wave. So this is suggestive of left ventricular hypertrophy. So it isn't unusual that the cardiac access is heading towards lead 1 because you're getting an enlargement of the left ventricle. Having said that, that access could be normal for that patient, but it is interesting that it heads particularly towards lead 1. I sometimes say to my students, what about a very fit person who does a lot of gym work, a lot of marathon running? They also could have an enlarged left ventricle and could show these signs of tall R waves. How might that differ? Well, of course, students will say to you, look at the patient, they're a fit young person, whereas this patient is obviously got some kind of pathology that's caused this. But the other, of course, is the pulse rate. The fit young man, or young woman, I do apologise, could have a very slow heart rate, is likely to, whereas this patient is unlikely to. They may have a normal or higher heart rate. Of course, they could be beta blocked if they've got a underlying heart condition. The other thing is, in the younger person, the T waves tend not to be inverted, of course. In fact, they can be quite peaky and quite tall. So heart rate would differ, T waves would differ, and obviously looking at the patient, getting your history, would show that they were a very different presenting patient. So here we have sinus rhythm, heart rate of 75, and we see signs of left ventricular hypertrophy over V4, V5, V6, which are the chest leads which look at the left ventricle. Notice the inverted T waves, notice also the deep S waves in V1, V2 to a degree. Well, there we are. That's the end of the taught part of the workshop, so well done on completing that. The secret to 12-lead ECG interpretation is to work systematically and to practice. And in line with that, what I'd like you to do now is to take a pad and a pen, and perhaps make yourself a drink, and to work systematically through the examples that I put online for you. You know, it's very tempting to have an early look or a peep at the answers, but try not to do that, because this won't give you the opportunity to practice the elements that I've taught you. In terms of resources, there's a great deal of material out there, as you know, and the issue is to choose something that's right for you and to take time to do that. If you want to go back to basics, that's absolutely fine. There'll be something for you. Or if you're feeling more confident and competent, there's plenty of resources that will presume that you can review systematically and will just focus you in on the abnormalities that the 12-lead ECG is showing you. There will be something for you. Good luck with your clinical practice, and of course, good luck with your 12-lead ECG interpretation. Thank you for joining me.